When a man or any patient presents to me with sexual dysfunction, he doesn't come with a single symptom. He comes with his occluded vascular system, sabotaged metabolism, hijacked hormones, impaired mental well being, erratic lifestyle, and often one or two underlying non communicable diseases. So, to view this symptom of sexual dysfunction in isolation may be clinically convenient, but ethically and scientifically definitely incomplete. My allopathic modern medicine is wonderful. It's got a lot of new drugs. We have advanced so much. We have robotics. We do organ transplants. But my traditional system, Ayurveda, reminds me of balance, restoration, and prevention. So it's not a fight between modern medicine and traditional medicine. But what I want to say is that there has to be a holistic approach where male sexual dysfunctions is not about just giving PD5 inhibitors. So if you're giving PD5 inhibitors like Viagra or Tadalafil to your diabetic patients, it's just like giving paracetamol to a patient who's got typhoid. Are you doing any service? Are you doing any justice to you? Every sexual dysfunction, friends, comes with as a marker of some or the other metabolic disease, be it diabetes, hypertension, obesity, dyslipidemia. So if I want to treat holistically, I need to address many things. Most important, lifestyle, metabolic health, psychosexual factors, and of course, give him validated, ethical, patient-safe therapies. Over this next 25 minutes, I'm going to give you some shared distilled insights and some nuggets of conceptual understanding as to how to treat, how to manage the most common male sexual dysfunction, erectile dysfunction, which is definitely outspoken or not spoken at all, but yet central to our health, connection, and of course the moment of life itself. With pranams to God, with pranams to God and thanks to my teachers, late Dr. O.P. Kapoor, Dr. Kothari, and Sashank Joshi, I beseech them to bless me always. Mitro, look at our Prime Minister. His hands are down. He was very, very helpful to us, and he is, because he gave us GST and lockdown, which was definitely important for us. Then he told me, Deepak. So I said, look, my hands are up. I said, I will also offer unlockdown and GST. And my GST to all of you is great sex therapy. My talk today is because every human being has a right to a healthy and satisfying sexual life. So true. The latest trend in India is ED is rising in younger patients today. And India is also having high prevalence of diabetes, hypertension. I've yet to come across a family in which there is no patient of hypertension or diabetes. In Mumbai, every third Mumbaiker is a diabetic. And patients don't talk about it. It's whose fault? Let's see. The whole scenario today has changed. Women are empowered. They're least bothered about financial insecurities, which they were bothered about in the past. They are earning an equal more to men. So if financial insecurity is not an issue, what else a partner needs? And we are having a metabolic chaos. Diabetes, hypertension, obesity don't just coexist, they conspire, silently dismantle metabolism, stiffen blood vessels, numb nerves, and steal sexual functions and vitality. Together, they are crippling the quality of life and turning metabolic imbalance into a lifelong cardiovascular disability. So when we look at the current scenario, diabetes is an established risk factor for sexual dysfunctions in men. Not only that, but today it has been proven beyond doubt that erectile dysfunction associated with undiagnosed pre-diabetes and type 2 diabetes. Undiagnosed. So you can consider ED to be a diagnostic marker of diabetes also. Pre-diabetes, according to me, is not something which has not happened. It's a disease itself. It's disease already there in the patient. Okay, it's progressing, it's perilous, it's pathologizing diabetes. Don't ignore it as a mild disease or not yet diabetes. Everything what happens in diabetes also happens in pre-diabetes. In fact, the incidence of erectile dysfunction is 3 times more in pre-diabetics than in diabetics. So when you think of diabetes and sexuality, 3 things which we need to understand. The earliest marker is erectile dysfunction, and these patients have low testosterone. So we need just not to focus on HbA1c and variability and all other things. We need to focus on many other things also. Hyperglycemia reduces GnRH. That's the reason why testosterone is off. It's endothelial dysfunction. We have less nitric oxide or no nitric oxide. Why does the endothelium gets disturbed? Even slightly rise in sugars, slight rise in hypertension, and slight rise in lipids will definitely destroy or even dysfunction the endothelium, which will result in less enos, less L-arginine, and less nitric oxide, which is the initiator of the whole erectogenic process, is the chemical currency or the molecule of life, which through various cascades of effect produces erection. So today you are only as old as your endothelium, because biological aging, which is very important, depends upon the health of endothelium, depends upon the cumulative vascular injury, metabolic, inflammatory, and oxidative stress exposures. So aging is not counted in years, it is encoded in the endothelial nitric oxide signaling. And today, we shouldn't be worried about. We have a lot of strategies to improve our endothelial dysfunctions. Dr. R.D. Late, he suggested several strategies to improve endothelium. So many medications are available. Not only that, in diabetes, we don't just see endothelial dysfunctions. These all patients tell us, Doctor, kamzori ho gaya, bahut thakaan ho jata hai, thak jata hu. And that's due to mitochondrial dysfunctions. And we have a beautiful drug in the form of imeglimin, which can improve the mitochondrial dysfunctions which is there. So there's definitely a link between diabetes and sexual dysfunctions, obesity, hypertension, sleep apnea, we just heard about it, depression, changes in testosterone, impaired blood flow, high levels of glucose damaged nerves, so neuropathies also. So all these things contribute to the symptom of erectile dysfunctions. And there are newer things, newer pathological depths, which NLRP3, inflammasome, pyroptosis, ferroptosis, epigenetic and microRNA 155 upregulations. Even endothelin 1, which is upregulated, results in inflammation, oxidative stress, and nitric oxide reduction in production, leading to diabetes-induced erectile dysfunctions. So friends, diabetic erectile dysfunction is a manifestation of endothelial mitochondrial disease or dysfunction marked by nitric oxide deficiency and vascular. It is not just vascular failure, it is neurovascular, hormonal, inflammatory, and epigenetic failures combined. So to sum up, what I say is, in diabetes, sexual dysfunction is not a taboo. It's not a vulgar thing, it's not a bad thing. It's a tool, it's a signal, your body is giving you a whisper, listen to me. According to me, the most honest organ in our body is not the brain, not the heart, not the liver, not the kidney. It's the penis. It reduces its solute moment your endothelium goes bad. And from the development of erectile dysfunction to the onset of myocardial infarction, the duration is around 8 to 10 years. So that's a signal your body is giving you. You have enough time to counsel him, tell him everything about lifestyle modification, reduce the risk factors. So it's a vascular disease which is giving you a signal of. It's not shameful or awkward, it's biological, and ignoring it costs more than intimacy. Sexual dysfunction and diabetes, our bodies whisper and signal much before the heart screams. So sexual dysfunction in diabetes hence should not be called as a sexual dysfunction, but called as a vascular dysfunction. My patient's ECG is in his bedroom. The moment he tells me that he's got ED, I think he's going to get MI sometime or the later. So I don't have to go do angiogram. My cath lab is my patient's bedroom. Very simple. I don't have to send him to a cardiologist. So diabetes does not just raise blood sugar, but very quietly enters the bedroom. So it does affect the individual, does affect the partner, and there is definitely a dent in the relationship of theirs. Now, it's so obvious. When we lose something, we feel the importance of it. Sex is like air. It's not that important unless you aren't getting any. So that's how it is. So how do we treat today ED? How do we treat? We have first oral drugs in the form of sildenafil, tadalafil, udanafil, vardenafil, and now new kid in the block, avanafil. Then we give injections of papaverine in the intracavernous tissue. We have vacuum rectal device. We have intraurethral prostaglandins. And if all these fail, we send our patients for implant surgeries to the endosurgeons. But none of these therapies will work if you don't counsel your patient and send them for lifestyle modification for lifetime. It's not just for 1 or 2 months. It's all for lifetime you got to send it. We have 4 PD5 inhibitors which are available. The fastest onset of action is vardenafil or avanafil now. The highest duration of action is tadalafil, which is 36. All have got side effects of flushing, headache, nasal congestion, dizziness, dyspepsia. Visual disturbance is very common, and they are contraindicated in patients who are on nitrates or having anatomical penile defect or anemias or myelomas or leukemias. We have seen bluish, greenish halo with patients taking even 50 milligrams of sildenafil. We have seen central venous chorioretinopathy with 10 milligrams or 20 milligrams of tadalafil. Of course, reversible when you stop it. More serious effects are epilepsies or seizures seen in patients with it. Even malignant melanomas have been seen in these patients who are on PD5. But today, PD5 inhibitors have got limitations. 50% patients don't respond to it. It is used more as a recreational drug today by youngsters to impress their girlfriends. So that's what it is used for. I don't recommend PD5 inhibitors to any young boy. Then we have testosterone. Every lane in my city has got 2 or 3 gyms. And these youngsters, when go to the gym instructors tell him, "Main tere ko Salman Khan banayega." He gives him growth hormone, testosterone, androlone. This boy has got normal testosterone and you are giving exogenous testosterone. What will happen to his endogenous testosterone? It will get suppressed, and these patients develop azoospermia. At the cost of making muscle, they are becoming infertile. So that's the price they are paying for it. So there's definitely, we then did publish of stem cell therapy or PRPs, had little effect, but we still lack robust evidence.
Promoting cardiac angiogenesis as well as extracorporeal shockwave therapy for treatments in the field of urology. Metaspec now applies the same expertise to vascular-related erectile dysfunction with the ED1000. Applied to the penile shaft and crura, the ED1000's low-intensity shockwaves result in improved blood flow and accumulation of blood in the penile corpora following sexual arousal. An ED1000 treatment series results
Speaker is on.
improved erectile function with no cardiac angiogenesis as well as extracorporeal shockwave therapy for treatments in the field of urology. Metaspec now applies the same expertise to vascular-related erectile dysfunction with the ED1000. Applied.
We have avanafil, a beautiful new PD5 inhibitor. The onset of action is 15 minutes and less side effects like headache, myalgia, bluish-green discoloration. The most important thing is half-life is only 5 hours. So this is the only PD5 inhibitor which you can give it to your patients who are on nitrates. You have to counsel them and tell them not to take nitrates when they are taking avanafil. So he skips nitrate on that day. So there is no nitrate in his body. Then he takes avanafil. Once he takes avanafil, the onset of action is 15 minutes. This drug washes out from his body in 5 hours. So there is no avanafil left in his body. And next day, he can have sex on that day and take his nitrate again on the next day. So this has been studied very well. We have films of sildenafil and tadalafil, faster onset of action. We have melatonin, which reduces in patients with ED due to various reasons. So if you give them melatonin, they have good erections and also they get very good circadian sleep. New ointment or gel which is available, which is to be applied on the glans penis. It has got no compound. It has got ethanol and some other things which are not chemical compounds, and patients get good erections in 10 to 15 minutes. We have also done a study on this. And this is US FDA approved, available over the counter everywhere in the United States and now also in India by the name Penegra XL by Zydus. We have glyceryl trinitrate, which we can apply it on the shaft of the penis because of its side effect of improving the blood supply or dilating the blood vessels, and it can be given to patients who are diabetics also. Bariatric surgery. My friend Dr. Jyoti Dev gave his patients insulin pump and found 84% improvement in these sexual dysfunctions. Intracavernous tissue, we should be very cautious about giving this for the fear of priapism. If he gets priapism, it should be attended immediately. If not attended, this patient may lose his penis, he may get gangrene. Vacuum erectile devices which are available for patients who do not want to take medications, do not want to take injections and they are scared of it or they have side effects. This is the pump where a vacuum is created and the penis enlarges, and then this rubber ring gets attached to the base of the penis, and the patients, because of the venous stasis, gets erection and he can have sex. Then if all these fail, we send our patient to implants. Implants are surgical ways of putting implants in the penile shaft with reservoirs and pumps in the scrotum. Very expensive, 4 to 5 lakhs each. But if this fail or if there's infection, which is very common, these implants have to be removed and then cannot be re-put inside. So we've been treating ED for donkey's years, but none of these reverse the pathophysiology of erections, which is endothelial dysfunctions and myocardial dysfunctions, nitric oxide deficiency. So if we want to do that, what should we do? What should we do ethically? We know that endothelium nitric oxide is very important. It's not the PD5 inhibitors. They come very late. They come only when you have enough nitric oxide. So if we want to improve or give them ethical cure, we need to give them nitric oxide, So nitric oxide reduces as we age. At the age of 60, we'll have only 15% night. And loss of nitric oxide is associated with atherosclerosis. The discoverer of nitric oxide with L-arginine got Nobel Prize. These 3 brilliant scientists discovered L-arginine and nitric oxide, very important for vasodilatations. I was very fortunate to meet Dr. Farid in India. So there's a Dr. Nathan Bryan, who's done 2,000 studies on nitric oxide. Is the audio on?
Conditions. It's low blood flow, what we call focal ischemia, inflammation, oxidative stress, and immune dysfunction. Nitric oxide corrects all of
Nathan
these.
Bryan is explaining to us.
So how do we biohack to improve nitric oxide?
50%
The earliest stages of
we get it from the endothelium, from L-arginine. The rest of the 50% we can get it from a diet. The beetroot, green leafy vegetables, nuts, pomegranate, watermelon, citrus fruits, sage, garlics. These are all nitrate-rich foods. When you chew them, your salivary microbiome converts them into nitrite, and in the stomach it gets converted into nitric oxide. So you have another source of getting nitric oxide. Don't have to be disheartened that your endothelium is not working, so you don't get nitric oxide. You can't get good sex life. No, you can, with the help of these nitrate-rich diets. Then there's a third way to get nitric oxide. Our paranasal sinuses are rich reservoirs of nitric oxide. If you do deep breathing, deep inhalations, you get nitric oxide. A tremendous, beautiful source of nitric oxide is paranasal sinuses, which have been proven. And the fourth way to get is chanting mantras. In Ayurveda, they also call it mantra chikitsa as a beautiful treatment for increasing nitric oxide. So we have 4 different ways to get nitric oxide, which is the molecule of life, which is the currency of every cell. We have been using PD5 inhibitors for 17 years now, but we have not got any good effects. So how do we treat these patients? I am reluctant to give PD5 inhibitor. I give very less PD5. Even if patients ask them, I tell them not to take it. Correct the root cause of it. Some patients who got hypogonadism, I was told to give some thought on testosterone. So when to give testosterone? Testosterone, according to me, is a double-edged sword. On one edge, testosterone gives strength, libido, bone density, cognition, vitality. But on the other edge, it's when misused or overused, like how it is done for youngsters, it brings erythrocytosis, cardiovascular risk, infertility, and behavioral changes. It's the same molecule, but different outcomes. The difference is not in the drug, it's how we understand it. So how do we give it? If it is primary hypogonadism, which is in the testis, okay, you need to give them, if it is functional hypogonadism, which means if he's got obesity, diabetes, OSA, and many other things, you can restore testosterone to a physiological level. Okay, but monitor PSA and explain to them counsel them on fertility issues. Okay, but if he's got secondary, which is in the hypothalamus, like Kalman syndrome or Klinefelter's or Prader-Willi's, they may need a different way of treating with testosterone for a long time. Leave that with the endocrinologist. But for sexual dysfunctions in patients with diabetes, hypertension, dyslipidemia, obesity, this functional hypogonadism, we can give them testosterone, but monitor PSA and check for fertility issues. You can give them 100 milligram of testosterone undecathyonate intramuscular once a week for 6 weeks, or 250 milligram intramuscular once in 3 weeks. We have beautiful gel, 1% gel available to be applied on non-hairy portions once a day for at least 3 to 6 months. It's the best way to give. Monitor PSA is a must, and this gel is to be applied on non-hairy portions of the body. In obese patients, please try to avoid giving testosterone. This low testosterone in obese patients is due to aromatase. Aromatase converts their testosterone into estradiol. Do their estradiol levels. If they are high, prove it that he's got testosterone, but that's getting converted. You can give them aromatase inhibitors or reduce the weight. Try and tell them to reduce their weight. Automatically, the endogenous testosterone will produce. So this is the simple thing which you can understand to give testosterone to functional hypogonadism patients. Don't think about giving it to secondary. Let the endocrinologist treat it. So let's think deep. What are the options we have to make eel into a whale? First, we must not do any harm to our patients. Primum non nocere. Do we have something to give to our patients with erectile or desire issues beyond PD5 inhibitors? Do we have something in our life? Can we give them something safer, something more body compliant? Yes, we have fenugreek, proven beyond doubt. Fenugreek extract in a supplemental form, we have studied argine ED studies. 330 milligram of fenugreek in a saponized form in 3 months increases the testosterone to 20 to 25%. Proven doubt. Because the mechanism is the testosterone molecule and fenugreek have a similar chemical composition. So it displaces the globulin found testosterone and makes the free testosterone more available, which is the more bioavailable testosterone responsible for desire in a patient. So according to the male sexual response, desire is the first thing which is taken care of by fenugreek. Okay. So fenugreek is a herbal testo, you can call it. Okay. And it has got no side effects. Then is erection, which is nitric oxide. And we know L-arginine is a nitric oxide donor. We have L-arginine available to us. We can give them 2.5 to 3 grams of L-arginine. Multiple benefits with L-arginine. Studies beyond doubt, L-arginine and ED improvement. These herbal remedies are holistic, body compliant, restore homeostasis, and have no side effects at all. So let me give you a deeper perspective. Friends, our body is a biological machine in action. Diabetes and pre-diabetes are hyperinsulinemia and inflammaging processes which are going on in the body. Okay. And diabetes is the sexual health tsunami of our century. It's a manageable metabolic malignancy. Trust me, it is a malignancy for us. So my serious plea to all of us is, the future of medicine will not be defined by more prescriptions, but by metabolic literacy. If we are able to metabolically literate metabolism to our patients, if we teach the next generation how to eat for cellular intelligence, we will not just extend lives and will protect vitality, cognition, sexual health and dignity. So the revolution is not technological. We have a DTT conference coming on next week in Mumbai. What are the technological things going to do? I don't understand. It's nutritional, and it begins with the courage to change what we put at the end of our fork. So why preventable diseases cannot or are not being prevented? Why? Whose fault it is? Every year ADA, EASD all claim to be rising diabetic incidences in millions. Why? It's because we do not need more heroic interventions at the end stage of disease. We need earlier metabolic corrections at the pre-disease state. This is what we need to, and that onus is with we physicians. We have known the families for ages. If a 30-year-old boy comes to me and he has a family history of diabetes, hypertension, I need to raise my antenna. I need to ask him histories of erectile dysfunction. If he has, that's a whisper which body is given to him. That's a signal which is given to him that he may have cardiovascular disease later on or coronary artery disease. So I need to change his lifestyle. It's the onus is on me. It's not on him. So friends, diabetes is an inflammatory disease. We all are in a pro-inflammatory state. Muscle is anti-inflammatory. Fat is inflammatory. So to rekindle the sparkle of our life, we must build muscle and burn fat. So it's a need to change. Patients don't hide. Doctors don't ask. Every doctor who doesn't ask their patients' histories of sexual functions, I think he's got ED. And that ED is educational discomfort. Educational dysfunction. Okay? Or he's got clinical avoidance. Or he's got conversational taboo. Why? Is penis not a part of the body? When he's passing urine, does he get it from the cupboard? Or when he has sex, does he get a cupboard and apply like a USB and then goes to this? It's a part of a body. When you're treating a body, it's a part of a body. What's wrong? When you got slight refractory error, you go to an ophthalmologist. Okay, so when you have these issues, you can go. Nothing wrong. Take treatment. It's cultural anesthesia which we've been told not to do, not to ask about it, not to think about it. He'll become judgmental. What he will think about me? I'm this, I'm that. All these rubbish things, we should come out of it. It's selective blindness and deafness even with a stethoscope. Okay. So one question from a doctor changes everything. Any concerns about sexual health or do you have problems in making love will make a difference. Now my next 3 slides are very, very important. Not only for you, but for your patients. There is something called as sirtuins. These are anti-aging amino acids, which are abundant in Corpora cavernosum. Now, when these anti-aging amino acids are activated, your lifespan, health span improves. Your weight reduces. Free fatty acids disappears. Inflammation subsides. So caloric restrictions will improve your mitochondria and your cellular functions, and you will have lifespan expansions. Caloric restrictions. I'm not giving you any medications, friends. No drugs. Caloric restrictions. This is the first thing we should take home. Lots of studies to prove. Lots and lots of studies to prove. Second is autophagy. Our body has an innate mechanism to clear the kachara of the cell. Imagine in your bedroom there's a dustbin. Every day you put something or other in the dustbin and don't clean it for months and years, and what will happen to your room? It will stink. But our body has an innate mechanism to clean the debris of each cell which is formed every day. All the DNA, which is all mitochondria, dead cells, etc., all the organelles which have not been functioning, they are all present. That needs to be removed. And that can be removed with fasting. And the discoverer of this got a Nobel Prize. And that's called autophagy. That's the second one. And the third is hormesis. I can't walk, doctor. I got severe knee pain. Arey, that's stupidity. You start walking 5 minutes. Stress your body a little more than what you think can scare you or put you to severe pain. So stressing little more than normal. If you're taking a warm water bath, at the end of warm water baths, just take 30 seconds ka chilled water bath. Put your hand first, then feet first, then body. 30 seconds only. Bring a change from hot to cold. You are acclimatizing your body to the stresses. So third mechanism, no drugs. Again, no drugs. So all these three things will improve, will be an adjunct to your lifestyle. So if you improve your lifestyle for lifetime, your pro-inflammatory status improves, oxidative stress, endothelial dysfunctions all improve. So my friends, your fork, what you eat, is more powerful than your prescription. You don't need a new diet, you need a new lifestyle today. Very important. Because medicine is not healthcare. Food is healthcare. Medicine is for sick people. It's time we realize this. Medicine treats diseases. Lifestyle prevents the diseases. Hospitals will repair the damage. Your kitchen will prevent the damage. Perfect, ma'am? 2 times Nobel Prize winner. Who gets Nobel Prize? 50 years of research. This man, when he received his second Nobel Prize, he announced to the world that nearly all diseases can be traced to a nutritional deficiencies. Is he telling a lie? Will he get a Nobel Prize? And what should we learn from him? Dean Ornish proved severe coronary artery disease with intensive lifestyle changes improved completely. No stents, no statins, nothing. Cleveland Clinic in their original studies said nutritional intervention not only halted but even reversed the coronary artery. Such a huge plaque completely opened up without stenting, without bypass. And we are all medical people. The father of medicine, William Osler, what did he say? One of the first duties of the physician is to educate the masses not to take medicines. Was he a fool to tell that? We call him father of medicine, right? So the art and science of sexual fitness is not based on anything else but what you put in your body and what you do for your body. If you put kachra, you'll get kachra. हमारे हिंदी में कहते हैं कि जैसा अन्न वैसा मन और जैसा मन वैसा तन. So if you want your tan to be better, your an has to be better. Okay. So let's rekindle the sparkle of our life, the fractured libido, and turn. This is our first study. The results of the studies were fantastic. We have issues our partners don't have. We deprive them of all the pleasure which she deserves. And this is not respecting feminism. This is injustice. Men shy away, they avoid, they give excuses. They feel they'll be judged upon. So feminism needs to be adored, admired, and respected. We have 4 PD5 inhibitors available today, but they don't increase the desire. 40% patients don't respond to it. क्या करेगा? So many patients buy it from the chemist. Doctor, कुछ नहीं हुआ. 100 में 500 रुपए का गोली लिया, कुछ भी नहीं हुआ. Then we give them testosterone. Bacha. But we have to give it caution. We can't give it to younger patients. We can't give it to old patients. Heart failure and prostate issues. So who's the Raja of all? Fenugreek, L-arginine, regional medicine, lifestyle, and activate serotonin's autophagy and hormesis. Is this costing any money? Do I have to spend anything for this? Can I not treat sexual dysfunctions with just this? So, with L-arginine, fenugreek, and lifestyle modification, simple. So what a physician misses, you don't give time. My teacher tells me, Deepak, I see 110 patients a day. How can I talk about all these things? I say, sir, you don't see 110 patients. 110 patients see you and go, sir. You don't see them. So give them an emphatic here. Okay. Ask, 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 ask. Educate, 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 educate. So what is an ideal prescription of a diabetic with ED should be? Counseling and lifestyle measures to be adopted as soon as possible. OHA, insulin, if OHA you prefer, give them metformin, SGLT2 inhibitors, imeglimin, acarbose, and basal insulin. With this type of OHA and insulin, who cannot control sugars, tell me? all of us sitting here can control everybody's diabetic. Statins if dyslipidemia, antihypertensive, ACE, ARBs are the best. If you want to give beta blockers, only nebivolol. If you want to give diuretics, give indapamide. All others will give them sexual dysfunction. Low dose PD5 inhibitors if no contraindications. Low dose short course of testosterone if no contraindication. Monitor PSA. L-arginine with fenugreek, zinc, etc. Nutritional interventional counseling and mental health checkup. My last 2-3 slides. Friends, there is no law which says you must age. Why you should age? Chronological age jo hoga hoga, but biological age to reverse is in your hands. I am 70 today. So what? Nothing wrong. Don't blame your genes. The science of genes is completely changed. If you are able to have sex, men, your coronaries are clean. Because coronary arteries have a larger diameter than the penile arteries. So if your penile arteries are clean, you have good blood flow, you have good erection, automatically your coronary artery, you will not die of heart attack. So keeping coronaries clean is treating ED before myocardial infarction storms. Friends, when stress becomes chronic, metabolism is sabotaged, hormones misfire, inflammation rises, immune system impairs, sympathetic drive overtakes, sleep fragments, joy disappears, and sexual functions decline. But if your nutrition is adequate and optimum and ideal, if your mind is peaceful and your relationship between you two is respectful, sex becomes an experience, not a threat, not an anxiety at all. Medicine has got no ego. My Ashwagandha, Shilajit has got no ego. What is wrong? They are safe. Medicine is service. Is medicine to be blamed for anything? We have ego. Why should I use Ashwagandha? Why should I use Shilajit? My PD5 inhibitors are much. What PD5 inhibitors? Show me one PD5 inhibitors were researched for hypertension and angina, not for erections. Okay, so now I'm going to give you 3 vitamins which we all are lacking in. And they need not be bought. They can be inbuilt from us. The first is vitamin touch. Couples hardly touch each other. Touch has got a fantastic benefit. Vitamin romance. Beautiful. Don't cost anything. Imagine the days when you were romantic, how nice you used to feel. And last is vitamin gratitude. Be thankful for all you have today. I was touched by our Prime Minister touching me. Who can go so close to him? He told me, मेरे घर में चाय पीने को आना doctor. I was so touched. This keeps on moving in my mind all the time. That's all. These are my books. Amongst them, the best book is nitric oxide. I can send it to anybody. Please send me an email. I will send a PDF copy to anybody free of cost. So my last slide is, friends, endothelial and mitochondrial dysfunction, nitric oxide deficiency are the root cause of ED. 21st century nutrition is not a lifestyle choice. It's the most powerful determinant of who ages with vitality and who ages with disease. That's a choice we have. Fractured libido can be healed without hormones. Endothelial dysfunction, mitochondrial dysfunctions can be restored. PD5 inhibitors are effective but have adverse side effects. Beyond medicines, erectile dysfunction in diabetes can be managed. Combination of fenugreek, L-arginine are proven to be effective and safe. Lifestyle modification and treat the root cause of ED is a must. Erectile dysfunction is a correctile dysfunction. And if you do so, friends, sex really has no expiry date. And thank you all for your love. I'll be happy to answer any questions you have.